Well, let's move on and talk a little bit about the operation. What are the differences between a primary total knee replacement and the revision total knee replacement? You know, simple things like, I'm assuming it takes a significant amount of time longer. It's a little bit more involved, a little bit more equipment involved with that, since you do have to remove parts of the knee. But describe for me the difference between you know, what goes on in the operating room, what the surgeon has to think about when they're doing a primary versus a revision total knee replacement.
When a surgeon does a revision total knee replacement, the thinking starts the minute he sees the patient, looks at the x-rays that are in front of him, and begins the surgical planning. If you plan correctly the flow in the operating room and your ability to get the patient out safely with the goal of a stable knee through a full range of motion can be met. Let me give you an example. Sometimes when people fail a previous knee replacement, they have associated loss of bone, where some of the polyethylene wear debris has worn away some of the bone that was previously there. So the patient does not have as much of a base to put the implant on. The surgeon has to be prepared to address this issue in the operating room, which means a revision surgeon will have, number one, the proper tools to remove the previous joint replacements that's there to not cause more bone loss. The second thing is he may need some bone from either a bone bank, which is cadaver bone, or some type of synthetic bone substitute to substitute for the bone loss. And the third thing is he may need to bring in different types of implants that have metal augmentations, which are metal blocks that compensate for the bone loss. If the surgeon is not prepared for those series of events, all the what-ifs that can happen, it's going to be a very long and terrible experience for everybody. But a good revision surgeon has all the tools to remove and all the necessary bone, ligament, and metal implants to be able to compensate for what he or she can see. It's almost like being a Navy SEAL and being prepared for anything that could happen. In the operating room itself, the first level is the proper removal of the implant. And this includes an exposure, which means an incision and removal of scar that takes into account knowing where the scar is and where the ligaments are. And an experienced joint replacement surgeon will be able to tell that difference and be able to preserve the ligaments. So the exposure is extremely important, that it's done with the most minimal amount of trauma, although you have to take out a lot of scar tissue. As soon as you expose the knee and show the problem completely, the next step is the actual removal of the implant. Now, sometimes the implants are loose, so they come out quite easily. Most of the time, if they failed because the plastic failed or the metal cracked, then what happens is the metal sometimes is well fixed to the bone. And the surgeon has to use a series of very high-speed cutting tools or special types of ultrasonic tools to break the cement metal bond or the metal bone ingrowth bond and remove the implant without removing too much bone. Sometimes that is really the difference between an experienced joint revision surgeon and not, how much trauma they do to the remaining bone on removal. Ideally, you'd like to remove as much of the metal with moving as least amount of bone and leaving most of that behind, because you don't want to give yourself a situation where you've cracked a bone or caused a fracture in the bone while removing the implant. So removing the implant has to be with keeping as much bone behind and the most minimal amount of trauma. The next step is for the surgeon to step back, whether that could take 8 seconds or 8 minutes, however long it takes them, to evaluate essentially the landscape of what has happened now that the implant is behind. Where is there bone loss? Where is there more bone in one area versus another area? Are the ligaments intact? Are the ligaments strong? Can I build this up with metal and plastic, or do I need cadaver bone? And those are the decisions that go through. I call that developing the construct, or essentially the architecture. It may be a combination of all those things. Once that's done, the surgeon recuts the bone to fit the new implant or the new construct, which would be implant plus bone or implant plus metal augmentations. Once that's placed in, a trial is placed in, not the final, to see if you have a knee that is straight and stable through a full range of motion. Once that's done, that is cemented or fixed into place by whatever means the surgeon uses, and then comes the last step, which is the careful and meticulous closure of the knee to make sure that it's properly closed with the right amount of tension, and after it's closed to check the motion one more time to make sure the knee is stable through a full range of motion.
And how long does this take? I mean, I'm assuming that this is very variable in terms of how much work you have to do, but how long is the operative procedure compared to, for example, when you do a primary total knee replacement?
Well, time is a very interesting thing because some surgeons operate a knee replacement a little quicker than others, and I don't really think of it in terms of speed. I think of it in terms of rhythm. A good surgeon has a rhythm that follows a certain pace. But in general, no matter what is your time to do a primary, revisions are usually 2 to 2.5 times longer. For example, I usually can get out of a room with a primary knee replacement in a little under 1 hour. All right, I can do 100 knee replacements in a row, and you can average, by the time I'm out of the room, 50 to 58 minutes. On revisions, I'm looking at a solid 2 hours. On revisions that require bone graft plus metal augmentations, I may be looking at 3 hours because I have to fashion a bone graft to make it fit perfectly, and that could be a tedious process. So you're looking at 2 to 2.5 times, and sometimes 3 times longer than a primary to do a standard revision.